So a related issue I'd love to get your take on. It has to do with what I would suppose you would call the causal efficacy of any particular conscious perceptions or the contents of your consciousness at any given point. And to put this concretely, there's an interesting sort of unresolved problem right now in psychedelic medicine, which is, for those that are unfamiliar, although many listeners of this podcast will be familiar, if you give something like psilocybin to certain patients, they can have very, very profound therapeutic outcomes after just one large dose of psilocybin in which they have a full psychedelic trip, say. So, for example, I talked to this man named John Kostakopoulos on one of the podcast episodes. After a single dose of psilocybin, he went from being an alcoholic, a very severe alcoholic that would drink dozens of drinks at a time. In other words, to put this in control language, right, he could not control that aspect of his behavior when he was exposed to a single drink. So the problem was, how do you change this guy's brain so that he comes to be able to control that aspect of himself? And he has this first experience, and he has lots of imagery related to his alcoholism, and he sees things that are relevant to his alcoholism, and he stops drinking after that one experience. So here's the question, for which there's two schools of thoughts currently. One, is the actual content of that hallucinogenic psychedelic experience necessary for that person to achieve that full therapeutic outcome, or was it merely incidental? In other words, you could design a drug that had the same magnitude and enduring therapeutic outcome, but which didn't have the psychedelic trip to it. And so I'm curious how you would think about that problem, given what you've said so far about the adaptive nature and of these perceptual influences, that they are in fact models for how to control behavior, which in this case is the goal.
Yeah, it's a lovely example actually to bring up in this context. It's very, as you know, it's actually very current, right? And one way it's current, one thing that sort of surprises me in a way is that there is an active pharmaceutical research effort to develop non-psychedelic psychedelics, things that have a similar maybe clinical outcome or mechanism of action, but just don't have the subjective components. And for me, this is it's an empirical question, what clinical efficacy they will have. And it's made complicated by all sorts of things, such as the placebo effect and patient expectations and so on. But fundamentally, for me, there's a deep irony in trying to do that kind of thing. Because if you think about medicines in general, when you're looking for, let's say you're looking for a new compound to treat a particular disorder, there are typically three things you might look for. You want a substance that is not poisonous, not toxic to the body, ideally. You want something that is not addictive, ideally, so that there's less potential for abuse. And you want something that affects the system in question. You want if it's a problem with your digestion, you want something that affects the digestive system. If it's a heart problem, something that affects that. That's where you would look for good candidate compounds to explore for their clinical value. So when we come to something like mental illness, whether it's PTSD or depression or addiction, what's the system in question that you're trying to affect? It's not just the brain as an unconscious mechanism. It's your conscious experiences of the world and the self that instantiate particular patterns of behavior for you as the organism. And it's just interesting to me how, for instance, back in the 1950s, psychedelics were being widely explored for their clinical value, but of course that was shut down. And then it wasn't until 20, 30 years later, we had these SSRIs, these selective serotonin reuptake inhibitors that became Prozac and now many other brand names. And it's fascinating to me that the reason that these compounds became widely used was precisely because they did not affect the system in question. You could take an SSRI and you might feel a little bit anxious if it's the first time you've taken one or you're starting a new course, but it certainly doesn't wildly change your experience. But that's precisely why they were allowed to be used. And there's a deep irony there. Mm-hmm. So for me, the fact that psychedelics have an effect on your experience is an important part of the causal pathway by which they have clinical efficacy. It at least makes sense to me to think that way. It may in fact be that you could still get some effect through non-psychedelic psychedelics, but I do think it's likely to be very important. It's certainly important because in psychedelic psychotherapy, there's also this process of integration, right? So to really, in cases where it works, it's not just you put someone in a room, you give them a trip and then they go home. No, it's how you integrate the experience that they've had. And of course, for that integration process to happen, they have to have had an experience to integrate.
Yeah, I mean, that is the focal point of the subsequent therapy sessions, as I've pointed out elsewhere. And I thought your idea is really tied to this in a powerful way, because with a severe neuropsychiatric condition, it is your ability to act and to feel that needs changing. And so if I think all the things you're saying are an accurate view of what a conscious experience is, it seems to me, at the very least, very unlikely that you would be able to design a therapeutic that had the same magnitude of effect,
right,
but did not have the same subjective effects that psilocybin and other psychedelics do. I would guess. I mean, my sort of bet on this is they will engineer I mean, they're already doing this. You will make drugs that don't have the same hallucinogenic impact, and they will have some kind of antidepressant effect, say, but I don't think it will be of the same magnitude and duration of efficacy.
I think that's probably right. But I also, there's a note of caution on both sides of the argument here, because this example that you had of this chap who had one trip and resolved his alcoholism, I think these happen, but they don't always happen. And you still get relapses. And some of the clinical studies now, the first double-blind, well, you can't do a double-blind study with this stuff, but the first certainly large-scale clinical studies are not showing, cases where everybody dramatically improves in one arm of the study and nobody in the other. There is an effect. It's not as strong, certainly as we might have hoped to begin with. There are expectation placebo effects going on too. So I think there's a lot. Well, there's still just basically a lot of work to do in how because there's going to be individual variation too. Not everyone's going to benefit from a psychedelic intervention in the same way. It's a very personalized thing. But there is, to me, just to circle back, a very reasonable argument that the experience matters. And why does it matter? Well, one reason is, and this gets back to the other part of our conversation, that a psychedelic experience reveals to you in the first person that the way things seem in your conscious experience is not necessarily the way they are. Your perception is revealed. Your perception is revealed to be a construction in the first person in a way that can be quite powerful. That's one reason I think the experiential component is important for its potential therapeutic outcome.
Mm-hmm. No, I loved the analogy that you drew with a drug that was meant to treat something about the digestive system. Directly or indirectly, that drug is going to have to impact the digestive system, because that's the thing whose function is not optimal. But for these kinds of conditions, the thing that is not optimal is literally the thing in your brain, quote unquote, that is responsible for how you act and how your experiences feel in the moment.
Right. I mean, the counter argument again would be there might be a way to influence the brain that doesn't affect consciousness, but that still has the same therapeutic outcome. You're still affecting the system in question, which is the brain, but you maybe don't need to affect the conscious experience that goes along with particular brain states. And I just think maybe that's the case, but it seems unlikely to me, given this I think, reasonable belief that conscious experiences do have an adaptive function and they are involved in our behavior.